ladies and gentlemen. Shall we start? It's just gone past 9. I would like to welcome all present, particularly the Minister. Thank you, Minister, for your attendance. Members of this committee, the departmental official. I see we have one guest. Can I ask the members of the committee to introduce themselves, please?
Thank you, Chair. Good morning, everybody. My name is Christopher Fry. I'm a member of this committee.
Good morning, Chair. Good morning, Minister, and all the members. Dan Plato, member of the committee. Thank you.
Good morning, Chairperson, Minister, and team. Honourable members, my name is Rachel van Vogel.
Good morning, Chair. Good morning, Minister. Good morning, colleagues. My name is Khalil Brankis. Thank you.
Good morning. And the online members, please.
Good morning, Chair. Good morning, everyone. My name is Ayanda Barnes. Thank you.
Thank you, members.
Good morning, Chair.
And the departmental official, please introduce herself.
Thank you. It's Leslie Shand from the Department of Health in the Health Intelligence Directorate. Thank you.
Excuse me, was that an official?
Yes.
Thank you. Minister?
Good morning, Noma French Mbombo, the MEC for Health, and the person who is going to be leading from the department is Chief Director Ngosi, who's going to introduce herself, and any others who are here. Thanks.
Thank you, Minister.
Good morning, Chair and the members. My name is Nonhlanhla Ngosi. I'm the Chief Director Strategy, the Department of Health, and I'm joined by my colleague who had also introduced herself, Leslie Shand, Deputy Director for Monitoring and Evaluation. Thank you.
Thank you, Chief Director. Welcome. I see we have one member of the public in the chamber, and I don't know whether there are members of the public online. But the member of the chamber, if you could please introduce yourself.
Good morning, everybody. Good morning, everybody. I am Imam Tawfiq Eli from the metropolitan area.
Good morning, Imam. Welcome. Online? Nothing. Do we have any apologies? No apologies? If it's silence, then there's no apologies.
From our side, Chair, if I may, register the apology of the head of department, Dr. Kluti. He has a commitment for today, and his office had registered the apology as such.
Thank you, Chief Director. So noted.
Chairperson, my apologies. Honourable Member Baku Force is here. She just stepped out for a couple of minutes. She should be here within the next 2-3 minutes. Thank you.
Thank you, Member Plato. Well, with that, we will now move over to the department to brief the committee on the quarterly reports for the Department of Health for the period April to June 2022, the period July to September 2022, and the period October to December 2022. Chief Director, Minister.
First, thank you. Chair, just also to render my apology that after the presentation, I'll have to leave. We're busy responding to the issues of the protests that are happening. That's why I'm dressed like that. I have to go to some of the facilities, just for an apology, just in case.
Thank you, Minister.
And then also now, just my few 2 minutes introduction.
You're welcome.
The year 2022 is the year actually when, in terms of the pandemic, it was sort of a break, although we're not out of pandemic as yet, but it's the year, at least compared to the previous years from 2020, where it was at least a break from the pandemic. But it was also the year where we were integrating the COVID response to other health services. It was also the year that we're pushing for the vaccines, for vaccinations. It was also the year when we reflect and regroup, we realize that there have some of the health services that were left behind because the previous years were focusing on the pandemic. It was social well-being of the community in general was one of those, where specifically the adolescents and also the older person's mental health status. So other funding that were additional funding also went to those mainly to the adolescent mental health and the older person's geriatric mental health. It was also the year when we saw surgical backlogs were quite high, and as much as that there were even about 77,000 plus during from the 2020, but when we reflect on the year 2022, that's when we find that there were quite so many. That's the year that we committed also additional 20 million for those. And luckily, we also had the robotics and everything like that. Also, lastly, Chair, it was also the year we find that some of the communicable diseases like TB and HIV/AIDS, the services will find that they were actually also there was a issue of where we have a reduction of the patients coming in, especially for the ARVs, which is even now the issue of the second 90 of the people taking ARVs is as a result of what we have seen in that year. So it's a year of the regroup. It's a year of also where we have to do things differently, and also hence we had quite a lot of engagement with various stakeholders, so that for the committee to understand what year we are talking about, the year of 2022. But it was the year of hope. So I'll give it to Chief Director Ngosi to continue with the specifics.
Thank you, Minister, for that context and that background. Much appreciated. And we do note that you have to leave earlier. And thank you so much for what you're doing. I don't know how you fit 24 hours. I think you're fitting 31 hours into a 24-hour day, if I see what you're doing. Thank you very much. Then over to Chief Director Nkosi.
Thank you very much again, Chair, and good morning again to the members. I'm just going to share my screen and get ready to go on with the presentation of the departmental performance for the 3 quarters of the 2022-23 financial year. So the presentation will cover those areas. Oh, my apologies. I think I am reflecting a incorrect presentation. There's the correct one. My apologies. I had too many open things on my screen. So it's the briefing to the Standing Committee on the performance for the 9 months ending December of 2022, as I've indicated, within the 2022-23 financial year. So our presentation will cover those 10 areas. We will just give a context that will build on the context that Minister has just presented. We will then have a look at high level over these 3 quarters, how we've performed as the department. We will reflect on the quality assurance indicators that we monitor, women's health performance, HIV and AIDS as well as TB performance, child health performance, how our hospital efficiency indicators have fared for the 3 quarters, the Program 3 and Program 7 performance, as well as some high-level concluding remarks. So in terms of the context, Minister has already presented a context of where we found ourselves as the department in the year 2022-23. We have just emerged from 5 waves of the COVID-19 pandemic, and as at the end of the 3rd quarter, we were at 33 months since the start of the COVID-19 pandemic. We have found as the department that considerable efforts that were deployed countrywide to fight the scourge of the COVID pandemic, which included lockdowns, and all of those inevitably displaced most of the routine health services. So whilst we are getting a reprieve from COVID-19, but we are experiencing that all the efforts that were put in place to mitigate the pandemic did displace most of our services, as the indicators will reflect when I do the presentation. Also, the issues of a lockdown and other measures that were put in place have had profound impacts on the economy, the social well-being and education, and we are also finding increased societal vulnerability to poor health. Our health system is experiencing a marked increase in non-COVID service demands at levels that are even higher than those that we have had before the pandemic. We had always been under pressure before the pandemic, but what we are finding now since the 33 months of having gone through COVID is that the demand is now at higher levels than those. We continue to monitor the COVID-19 resurgence whilst we're recovering from it and bringing back routine services online. We are also continuing to be vigilant of other disease outbreaks, because I think one of the key lessons that we took from COVID is to be continually vigilant of disease outbreaks. So at high level then, in respect of our performance for the 3 quarters of the financial year, we are categorizing our performance in terms of those targets that we have achieved, which are in the range of anything that is 95% and above. Those that are partially achieved are targets that are for which we have achieved performance between 50% and 95%, and we regard targets where we have achieved less than 50% of what we had targeted to be not achieved. So for the 3 quarters of the financial year, it is as reflected on your screen, members, that we have achieved in the first quarter 60% of our targets, 66% in the second quarter, and 54% in the third quarter. Those that were partially achieved, it was 32% in the first quarter, down to 22% in the second quarter, which went up again in the third quarter at 37%. Not achieved, we had 8% in the first quarter, 12% in the second quarter, which was down again to 3% in the third quarter. For the 3 quarters, we were tracking a total of 65 targets in total. The next slide then still summarizes or breaks down the same statistics according to the programs, the 8 programs that the department is mandated for. As you would see on programs 1, program 6, and programs 8, we do not have targets that we were tracking for the 9 months period, because those are actually annual indicators. But for the rest of them, we have been monitoring and had targets for the 3 quarters, and we are just breaking down how those targets that we have achieved, partially achieved or not achieved in respect of each program, have now been reflected. Coming specifically then into the actual performance on our targets, we are starting by looking at targets relating to quality assurance within the district hospitals, program 4, regional and specialized hospitals, within the central hospitals, as well as tertiary hospitals in program 5. In these quality assurance indicators, we are tracking 3 indicators, which is patient safety incident case closure rate, the severity assessment code called SAC1 incidents reported within 24 hours, as well as our complaints resolution within 25 working days. So those are the 3 indicators under quality assurance that we track across the hospital platform. And if we can see on the screen in front of us, on the extreme right, we are consolidating the 3 quarters performance. So when I am presenting, I will be focusing mostly on those last 3 columns, because that's where we have now consolidated quarter 1, quarter 2, and quarter 3 performance. So in respect of these 3 indicators across our hospital platform, we have achieved the target of patient safety incident case closure rate, as well as the complaint resolution within 25 working days. The one that we have partially achieved is the SAC1 incidents reported within 24 hours. You would see that that is the trend in the hospitals in program 2, in the regional hospitals in program 4, and specialized hospitals also in program 4, as well as on the next slide in program 5, central hospitals, as well as in tertiary hospitals. So if I can then summarize this performance on the next slide, is that, as I've indicated, we have achieved our target in respect of how we resolve complaints within 25 working days, as well as the patient safety incident closure rate. However, we have been we had partially achieved the SEC1 incident reported within 24 hours, mostly because there has been an increase in the cases that were reported because there was a change in the definition, which expanded the category of incidents that need to be registered as SEC1. And we also had expanded our training as well as awareness programs for people to be able to report on these SEC1 categories. So the expansion of these has then resulted in it being impractical to be able to meet the requirement of reporting them within 24 hours to senior management. This, however, does not imply that these were not dealt with appropriately. It's just in relation to them being reported to all the different levels within 24 hours, which was not always practical. I will explain and expand on that a little bit in the coming slides. So if we look then at this, the SEC1 cases reported within 24 hours rate, exactly what I just explained. If we look at the top left graph, we would see that for the last 3 financial years, the number of these cases did not reach 200. But for the 22-23 financial year, which is the year under review, the cases went up exponentially to a little over 500. And therefore, that we had seen a significant increase, which was caused by the change in the definition to include more categories. And therefore, we also increased awareness and training of staff. But we experienced challenges with regards to reporting the cases within 24 hours. Part of the reason is because we've got some multiple reporting systems which impact on data quality and reporting. It is something that we are working on as the department to make sure that we synthesize this reporting, and you can report in one area which can feed into 2 or more different other reporting areas, but also reporting of these cases when they happen over the weekends to a district office or to head office is impractical because those offices work weekdays from Monday to Friday. Therefore, you would not meet the 24-hour reporting requirements if you would only report it on a Monday and it had happened over the weekend. We have also, as I indicated, seen a significant increase in the monthly stats of the cases in the SEC1, and this has mainly been driven by patients that abscond. If you can see on the graph on the bottom right, how the numbers of cases of patients that have absconded have increased over the financial year that we are looking at. And this was a category that was previously not included as part of SEC1. Our patient safety incident resolution rate for the last 3 financial years, including the year under review, it has always been above 90%, which is deemed as a satisfactory performance across all the programs. There has been a backlog of capturing at some of the facilities, particularly at Tygerberg Hospital. We are noting that the patient safety incident cases have been on the rise, and mostly these are due to patient abscondments, as I indicated, but also cases related to patient accidents due to patient falls. This is something that our quality assurance team is working with facilities on the ground to make sure that we put quality improvement plans to mitigate the risk of those happening in future. Then if we move away now from quality assurance targets and go and look at women's health targets within the program 2, which is district health services, we are monitoring those 4 targets as reflected on the screen. And again, if we focus on the last 3 columns to the right, which is the consolidated year-to-date performance on those targets, we would note that we have achieved the first 2 targets, which is the antenatal first visit before 20 weeks rate, as well as the mother postnatal visit within 6 days rate. In respect of the delivery 10 to 19 years in facility rate and couple year protection, those were partially achieved. And in relation to the delivery 10 to 19 years in facility rate, the issue of teenage pregnancy it remains high, with about 8,000 girls between the ages 10 to 19 having delivered babies so far in this financial year. It is an issue that we are really concerned about as the department, for which we are then looking for cross-sectional collaboration with working with the whole of government and whole of society, and discussions have also been initiated with the Department of Basic Education and community forums to really bring a multi-sectoral approach to us dealing with the scourge of teenage pregnancies. In relation to couple-year protection rate, our partial achievement has been affected by the issue of condom distribution, which was largely affected by issues of stock out on the contracts by the National Department of Health, on which we get the RT contract for our condoms, as well as the delays in the release of condoms by the South African Bureau of Standards, where these have to undergo quality control and testing. Also, condom distribution had remained a challenge, as well as the issue of sterilizations that have not yet fully recovered to the levels that they were pre-COVID, as we are now finding that other surgical procedures are being prioritized. It's not to say the need is not there, but in the order of priority, given what I said in the context that we are finding that now we have got more pressure, and when we prioritize, we find that the issue of sterilization tends to then find itself further down in the order of priorities. If we look at the antenatal and postnatal visits, we can see that the antenatal first visit before 20 weeks is on target, although our levels, if you look at the graph on the top middle part of my screen, has dropped below pre-COVID levels, and we have only 74% of the visits are under 20-week period. Also, we are finding that the absolute number of live births is decreasing, and the postnatal visits within 6 days is on target and meeting pre-COVID levels, but only 61% of mothers have a postnatal visit within the 6 days as the target requires. If we look in more detail into the issue of the delivery by the 10 to 19-year-olds in facility rates, we are finding that there is, if you look on the bottom right graph, that there appears to be a decrease in the number of deliveries in the province. However, looking at the graph above, the big graph on the top, the proportion of deliveries by under 20s is high at about 12%. And if you look at those categories of facilities, it's only the national central hospitals that have a rate below double digits, but all the other facilities are experiencing double-digit rates of deliveries by under 20s in our facilities. This is an issue, as I indicated earlier, that would require a whole of society approach with the focus on ensuring that we increase access to services for adolescents in areas where adolescents find themselves. We need to find them where they are at, because they are not coming to health facilities. We need to say where are they at, and how do we then bring those services to them in order for us to mitigate the scourge of these teenage pregnancies. If we look again at couple-year protection rate, we are finding that again our rates have dropped to below pre-COVID levels. And if we look at the issue of sterilizations, we have not yet fully recovered to pre-COVID levels, as we are prioritizing other more critical surgical procedures, despite the demand being there for people to sterilize. I had already indicated around issues of condom distribution, which was affected by availability issues due to condom contract challenges with the national department, as well as the issues of those condoms that were still undergoing tests with the South African Bureau of Standards. If we then move onto our indicators for ART, HIV, and TB, in that space we are tracking the 5 indicators: the ART adult remaining in care rate, 12 months, the ART adult viral load suppressed rate, our HIV positive 15 to 24 years rate, all drug-sensitive TB client lost to follow-up rate, as well as all drug-sensitive TB client treatment success rate. Again, the focus being on the last 3 columns where we are consolidating the performance of the 3 quarters. We can see over there that we have achieved on the first 3 targets, whereas the 2 targets that the 2 remaining last targets that relate to TB, we are partially achieving those targets. So in respect of the ART targets, although the ART adult remaining in care as the first target, although we're remaining in care, excuse me, although the ART adult remaining in care is meeting the target, our overall number of clients that are started on treatment is lower than we would like it to be, and only 55% of those are still on treatment after 12 months, which is an area of concern. On ART adult viral load suppressed rate, we are performing and have achieved the target, which is good, as well as on HIV positive 15 to 24 years rate. In respect of the TB indicators, we have really been affected severely by the impact of COVID-19 pandemic on access to services, as well as the health-seeking behavior of our patients. Also, this worsening socio-economic challenges have resulted in clients becoming more transient, and therefore adherence to TB has become more challenging. If we look here again on the HIV test positivity in more detail, we are finding that the testing rates are improving, although still just below pre-COVID levels. But we are finding that the positivity has been lower than pre-COVID levels, although we are seeing that there is a slight upturn in the 3rd quarter of this financial year. If we look at ART treatment initiation versus adherence, we are finding that people that are started on ART, again, the numbers remain low, below pre-COVID levels, as well as for patients remaining in care in terms of adherence. We are finding that those remaining in care in children is 60% and in adults is 55%. On drug-sensitive TB positivity, again, the testing rates are back to pre-COVID levels, which is encouraging, but the province is still, the positivity is still higher than pre-COVID levels, although appearing to be leveling off if we look towards the 3 quarters of the financial year that we are looking at. We are also looking at our drug-sensitive TB treatment success rate, and it is it has always been constant around 70 to 75% from 2019 up to June 2021. If we move to child health indicators, we are tracking 3 indicators here in respect of district health services, and that is immunization of the under 1 year coverage, the measles 2nd dose coverage, as well as the vitamin A dose 12 to 59 months coverage. Again, thank you. Again, if we look at the last 3 columns where we are consolidating the performance for the 3 quarters, we find that in respect of immunization under 1 year coverage, as well as the measles 2nd dose coverage, we have partially achieved those targets and fully achieved the vitamin A dose 12 to 59 months. The challenges relating to the immunization under 1 year coverage relate amongst other things due to a change in the child population, as some of the learners may be returning to other provinces due to socio-economic circumstances if parents now have lost their jobs and must go back home. Civil unrest affecting access to facilities in some cases. There have also been issues of vaccine hesitancy that have been exacerbated now because there were also issues of COVID vaccines, which has also had a spill-off impact onto the vaccinations that have long been in existence, which are local vaccinations of under 1s, as well as the decrease in contracted private providers, which we have noted and is under investigation. Also, in relation to measles second dose coverage, we have found that this one was particularly affected by the school holidays, as well as the issue of the decrease in contracted private provider contribution, which we are investigating. The issue again of vaccine hesitancy came into play here as well, and we are having a measles campaign that's underway to improve coverage. The vitamin A dose 12 to 59 months coverage was on target, and the performance was satisfactory in respect of that. So we are just now in this slide reflecting in more detail again the issue of the immunization under one coverage, where we are showing the public sector facilities and private sector facilities that we provide stock to, and what the immunization coverage for the under ones has been. It was also recognized that there may also be client movement between our facilities and private sector facilities, as well as movement of patients between provinces, which also affects this target. In relation to measles coverage, we have underperformed year to date, and we are below our target. And we are, as I indicated, we are particularly concerned around issues of vaccine hesitancy, which is a spillover from the COVID-19 vaccination and the anti-lobbying that has been happening in that space, which has somewhat influenced guardians of children who now are also hesitant on vaccinations of children that have been long with us. Also, the issue of the December holidays in respect of the third quarter usually has an impact on the vaccinations. If we look at the child health indicators relating to HIV and AIDS, we're looking at infant first PCR test positive at birth rate, the infant first PCR test positive rate around 10 weeks, as well as the ART child remaining in care rate, as well as your ART child viral load suppressed. So in terms of those four indicators, again, focusing on the last three columns to look at our consolidated year-to-date performance, we have achieved 2 out of the 4 indicators, being the second and the third target, and then we had partially achieved the first and the last target. In respect of the first indicator, the infant first PCR test positive at birth rate, there the reasons for our partial achievement is the unforeseen increase in birth positive rate compared to previous quarters, and we are linking this possibly to the issue of the migratory population that comes into the province during the harvesting season, and also therefore impacting on us not achieving our target for the infant first PCR test positivity rate. Then again, the other target we have not achieved, which was the ART child viral load suppressor rate. Again, this is a matter that we are investigating within our various forums that are looking at issues related to HIV and AIDS and related matters. Also, we are finding that the socio-economic challenges are influencing the health-seeking behavior, and poor client contact information also impacts us being able to trace and follow up patients. Children and adults are also leaving the province for significant periods of time, and therefore this makes it difficult for us to link them to care at the destinations where they go to. Again, if we now look at the prevention of mother-to-child transmission positivity rate, if we look in those graphs there in the third or the middle graph of the PCR test positivity at birth, where we've got the red arrow, we can see there that there was a higher positivity rate at birth for children and also at 18 months. And we are attributing that this could be impacted by the migratory farm worker population. So it's something that we are also monitoring and reflecting on as the department. If we look at the child viral load done and suppressed at 12 months, we are noticing that our child viral loads done at 12 months remain low. If we look at the performance from July to September of 2021. If we look at child health indicators in district hospitals, we are tracking those indicators of neonatal death in facility rate, the live birth under 2.5 kilograms in facility rate, the child under 5 years diarrhea case fatality rate, the child under 5 years pneumonia case fatality rate, the child under 5 years severe acute malnutrition case fatality rate, as well as the death under 5 years against the live birth rate. Again, if I can reflect on the last 3 columns for the consolidated performance year to date, we have achieved half of those indicators, and the other 3 are partially achieved. I will explain in the next slide the actual details for the variances on those that we did not achieve. If we are looking again at the regional hospitals, tracking the same indicators, we find that in the regional hospitals, we have achieved 2 of those indicators. We have not achieved the one of the live birth under 2.5 kilograms in facility rate, and we have underachieved on the child under 5 diarrhea case fatality, as well as the child under 5 years severe acute malnutrition case fatality rate. If we look at the central hospitals, again checking the same indicators, we have achieved on the live birth under 2.5 kgs in facility rate. We have achieved the child under 5 years pneumonia case fatality rate and death under 5 years. The ones that are not achieved is the child under 5 years diarrhea case fatality rate, as well as the child under 5 years severe acute malnutrition rate. And in respect of the tertiary hospitals, we have achieved only 1, and we have underachieved on the 2 and partially achieved on the 1. And we are then going to look at this slide at the overall general reasons for underperformance in some of these indicators. If you look at the neonatal death in facility rate, this one was largely impacted on by the pneumonia surge earlier in this financial year. And also we have had more recently the pertussis outbreak, which has also affected the neonatal death rates in our facilities. We have had no challenges with the live birth under 2.5 kgs in facility rate. That indicator has been largely achieved by most facilities. The child under 5 years diarrhea case fatality rate, this one is really, in fact, this particular one, as well as the pneumonia case fatality rate, as well as the severe acute malnutrition case fatality rate, are all affected by the socio-economic factors that have been exacerbated by the COVID-19 pandemic, which has resulted in social disruptions, food insecurity, as well as less breastfeeding. So we are finding that generally children that are presenting in our health facilities have poor immunity and severe illness. That's why all these 3 indicators have then largely poorly performed across the platform. Then the last one, which is the death under 5 years against live birth rate, the issue of the pertussis outbreak has had an impact on child death, and also we are also investigating those cases. Also, the unexpected spike in the pneumonia deaths affected the cumulative totals, and also there has been an increase across the health platform of severe acute malnutrition deaths, and this is attributable to the worsening socio-economic circumstances that we have been experiencing since the onset of the COVID-19 pandemic. If we look at the maternal care and delivery outcomes as reflected on screen, we are finding that in 22-23, we are finding an increase in the neonatal death rates into the upper figures of 9.1 and 9.4 and 9.6% in this year that we under review. And as indicated on the slide, in Q1, there was the surge in pneumonia cases experienced, which impacted neonatal and pediatric admissions. And more recently, the pertussis outbreak has had an impact on child deaths and overall the poor socioeconomic conditions that we have been talking about. We are also looking here at child under 5 years case fatality rate in our different hospitals in district, regional, tertiary, and central hospitals. And overall, the message in this slide is that we have seen a worsening increase in severe acute malnutrition deaths in facilities. If we look on the table at the bottom right, in 2019, which was the year before COVID, we only had 4 deaths across the platform. But since 2020, at the start of the COVID, we had 13 deaths, and then in 2021, we had 10, and in 2022, we have had 17. So since the onset of COVID-19, the impacts of it, especially on the socio-economic front, have resulted in us seeing all these severe acute malnutrition deaths in our facilities. Also, with child inpatient death, we have been tracking in relation to issues of the increase in pertussis cases, and more than half of these cases were reported in our province, and the majority were reported in children under 5 years, of which about 74% of those were children under 3 months. Amongst the 461 pertussis positive cases with data available on outcome, there were 6 mortalities that were reported, and that information we had received from the NICD. Here we move on to look at the efficiency indicators in the district, regional, central, as well as our tertiary hospitals. In all these categories of hospitals, we are tracking 2 indicators, which is the average length of stay, as well as the inpatient bed utilization rate. Across the hospital platform, we can see that, again, looking on the last 3 columns, that these both indicators were achieved in the district hospitals, in the regional hospitals, in the central hospitals, as well as in the tertiary hospitals. But although having met those targets, we are finding that we are experiencing severe bed pressures, which are unpredictable and really persistently relenting. Trauma and mental health pressures continue, and they are high and increasing and account for the majority of the pressures that we are experiencing on the platform. And we have also had a lot of pressure at the beginning of the year, which was due to the pneumonia surge. Our average length of stay, we find that we have been largely within target for our different categories of hospitals in the year under review. And our bed utilization rate, as you can see on the top graph there, that since the start of COVID, we have had an increase in our actual number of beds by 2.2% in our acute hospital platform since April 2019. But despite this, the utilization rate of these beds has still been increasing across the board because of the pressure that we are experiencing. And you can see, based on that top graph, that since the start of this financial year, there has been even more increased pressure on the beds as we now fully recover from COVID-19 and experiencing the impacts of COVID-19 onto our health platform. So on the bottom graph, then we are seeing that trauma and mental health continue to drive the service pressures in the hospitals, and both of these continue to show an upward trend in terms of our hospital admissions. Then if we move over then to the support services indicators, because the ones that we were looking at were the indicators on the service delivery platform, which is district hospitals in program 2 and also program 4 and program 5. We are now looking at program 3, which is EMS services, and we are tracking 4 indicators under EMS services, which is EMS priority 1, urban response rate under 15 minutes, EMS priority 1, urban rate under 30 minutes, EMS priority 1, rural response under 60 minutes, as well as EMS incident mission time under 120 minutes rate. On these indicators, if we again look at our cumulative performance for the 3 quarters, we're finding that 3 of the 4 indicators were partially achieved and only the last indicator was achieved. So in respect of our explanation for the partial achievement for the EMS priority 1 urban response under 15 minutes, we have found that we actually had an increase in hospital time when we come to the EMS colleagues come to deliver patients at these hospitals. Also, the general increase in demand for EMS services across the platform, the increase in certain incident types, as well as an increase of rural cases, as well as red zone areas. On the EMS priority 1 urban response rate under 30 minutes, we were mostly affected by issues of annual leave that impacted on the number of resources available, the inability to replace resources due to on staff shortages with overtime staff, as well as primarily trauma and MVA increases that affected the urban and rural response times, especially in the third quarter related to the festive season. On the EMS priority 1 rural response rate under 16 minutes, again, the issue of the increase in demand, especially on our national roads. Also in the poorest towns, there was increased demand for our services. Our limited resources had to be stretched to cover service areas, and also the standby initiative in rural areas was limited due to the restriction of overtime spending. In respect to the last indicator, which is the EMS incident mission time under 20, we have achieved that target, but overall the challenges that we experience in that space is the increased hospital times, which cause longer delays and which also then impacts on vehicle unavailability. The increase in demand experienced in both the in-facility transfers as well as those primary sphere ambulances available for the general public. Also the limited resources, which then translate in us responding slower than we would wish for. And lastly, in terms of mitigations, our private vendor contract with private ambulances is expected to be put in place before the end of the first quarter of 2023-24. So in all, with the EMS, the increase in demand for the services against constrained EMS resource environment has resulted and put increased pressure on the limited resources in that space. The last program on support services, which is program 7, we are tracking 2 indicators there, which is the percentage of child death cases reviewed by the Child Health Review Board, as well as the percentage of pharmaceutical stock available. In respect of those 2 targets, again, looking at the last 3 columns, we have partially achieved the first target, which is the percentage of child death cases reviewed by the Child Death Review Board. And this is mainly due to the issues of the volume of these cases. We are just experiencing exponential increase in the number of these cases. And also we have some vacancies in the space that the department has been struggling to fill. So we are actively pursuing recruitment initiatives to make sure that we can put in appropriate resources to be able to deal with the volumes that are coming on that platform. In terms of our percentage of pharmaceutical stock available, we did achieve the target, and in cases where there were stockouts due to poor supplier performance or part or in no delivery by suppliers, we have been addressing this through strict contract management and also through escalation to the National Department of Health, that is the custodian of the RT contracts from where we buy then our pharmaceutical stock. Then in conclusion, Chair, if we now just summarize over the categories of the indicators that we have looked at, on the quality assurance indicators, we have achieved the complaints resolved timeously and BSI closure rates. However, with the SAC1 indicator, this one has been affected by the increase in the categories that must be reported, which then has affected the practicality of us reporting these within 24 hours. But we are working on measures within the department to be able to see how we can get over this challenge of the timeous reporting. On women and maternal health, we are noting that the issues of postnatal visits need to be monitored. The issue of teenage pregnancies remains a concern and requires the whole of government and whole of society approach to addressing it. The issue of sterilization and condom distribution require close monitoring and prioritization. On the infectious diseases, the HIV and TB testing rates are increasing, although these are still tracking below pre-COVID levels. Our TB positivity rate still remains lower than pre-COVID levels, and our drug-sensitive TB lost to follow-up and those remaining in care remain underperforming. Our ART stats and those remaining in care also remain low. On child health, we are cautious and monitoring the immunizations. The severe illness is being seen in children who have poor immunity, and child and neonatal deaths need close monitoring. On the hospital platform, we are finding that there are extreme workload pressures, notwithstanding that we are meeting our efficiency targets there. There is unrelenting pressure on the hospital platform, which inevitably then results in surgery backlogs, and the driver of this mainly is trauma and mental health. On EMS, our performance is still below target, largely due to increases in service demands against limited resources. And lastly, on forensic pathology services, our challenges around caseload and vacancies affect our ability to do child death reviews timeously. That, Chair, concludes our performance for the 3 quarters for 2022-23. Thank you very much.
Thank you, Chief Director Nkosi, for a very well-prepared and thorough presentation. Before we move on to questions, when we invited members to introduce themselves, members Klaas and Bakker Vos were not in the house yet. If I could just ask them to introduce themselves for the record. Thank you.
Thank you very much, Chairperson. I'm Dombizane Gladys Bakker Vos. Thank you.
Yeah, my name is Moses Tembile. My surname is Klaas. Thank you.
Thank you, members Bakker Vos and Klaas. We will now move to the questions and answers session. Before we do so, Minister, is there anything you wish to add?
No, Chair, it's fine. But as I indicated earlier, that I'll continue online if I have to leave. Thanks.
Thank you, Minister. Members, can we move on to the questions? I see Member Windvogel, Member Fry, and Member Klaas. Let's start with those 3, and Member Bakker Vos. Let's start with those 3, and then we'll take the next round. Member Windvogel.
Thank you so much, Chair. Chair, allow me first to welcome the presentation from the department. It's just a pity that the minister didn't touch on the issue of the industrial action. Therefore, Honourable Chairperson, before we move to questions on the report, or to discuss the quarterly report, can I humbly ask the Minister or the Department just to give us an update on the ongoing strike of industrial action by the workers in the public sector and the impact that it has in our province, and how many deaths has been recorded, and how is the provincial government dealing with this strike action? If we can just get, just so that we do understand, and when we engage with people, we know that's what is happening in our province. Before if you allow that, Chairperson, I do have questions, but I really want to just get some information on that issue, because it's life as mense se lewens wat geraak word.
Members, as the member rightly pointed out, it's not on the agenda, and therefore I will leave it to the Minister's discretion to decide whether she wishes to respond to that.
Thank you, Chair. under normal circumstances, we will be focusing on that. We are presenting a report of 2022-2023. However, in health, we always talk about triage, which is you prioritize according to the green, the yellow, the orange, and the red. So hence, I did indicate that I have to leave. I won't be able to be there so that I could be able to conduct oversight, as may be aware that I was away out of the country. So it's part of prioritization. So therefore, the question that Member Van Vogel is asking is justified, because people want to know from the horse's mouth in terms of exactly what is happening. So I'm happy to respond, but however, the people from the department who are here are those who are only focusing on this, because she's Chief Director for Strategic and Support, which is this is part of her. She won't be able to respond what you're saying. And for me, I'll respond on the basis of the information that I have before I came here, as I'm going to the oversight. I can respond.
Thank you, Minister.
Just briefly, I just want to thank MEC Shana Fernandez, who was my person who was responsible during my time that I was away. But also just to acknowledge that last night, the National Health Council, which is others they call it MINMAC, also had an urgent meeting in regard to get an appraisal from what is happening in other provinces. The National Department, DDG, there's a DDG who's responsible to collect the information. Yes, indeed, especially when we hear what is happening across other provinces was presented. It is very serious. And in the case of the Western Cape, yesterday, things were quiet. In the previous days, things were quite hectic in Khayelitsha, Michael Mapongwana, Gooks, Mitchell's Plain, but mostly the Khayelitsha, that things were hectic in regard to up to the level that the protesters were denying staff even to enter the premises, those who chose not to participate in the protest. So this is what they were doing. Yesterday, there were some peaceful, during the lunchtime protests, for example, in Kalbrema. But now the question about, are there any deaths? At this stage, those deaths reported as allegedly caused by the protests. The evidence we have in front of us is that the people were already having serious illnesses. So there is no evidence suggesting that it was the cause. Whether there will have been a strike or not, the chances are they will have demise. So we don't have any that kind of a report. Just also probably to take the members back, in case maybe you might be aware, what is the cause of the strike? Mostly the people who are striking now is the Nehau. I hear from today's newspapers that there might be NUPSO who might be joining, but what is the, and you will have seen how I think it was the SATU and also Dinosa who condemn some of these barbaric kind of actions that has been done or performed or whatever by the other protesters, whether they are Nahau or not. It's neither there or neither there. But the issue, the background is about 3 or plus years ago at the National Bargaining Council, where the unions are represented. And from the government is represented by the national government through some of the minister, but the custodian is the DPSA. Ministry, but I do know that health and education, they're also part of the bargaining. So at the time, there was an agreement of the 3-year of the salary increase. And then when now Treasurer later on, at the time, the National Minister of Finance was the Utato Titombowen, indicated that where the country was at the time in terms of the economy, they will never be able to afford for such increases. and then there was an interdiction. The court cases it went up to the Constitutional Court in regard to that part of it. So it has been dragging throughout in regard to whether they still have to meet the increases that goes around 7 to 10%. Plus, I don't have much of the quite details, but it went up to the level when the government now currently said they could be able to afford about 3%, and then they added some other frills, which is the 1,000 per month and so forth, which is currently the unions, they don't support that 3+%. And also there's still processes of the negotiations. I think it is going to arbitration, but I'm not sure exactly what. So this is where things are, because now is saying that you made a promise, and also you mustn't dismiss the union's demands in regard to the salary increase without wearing the other caps. You mustn't dismiss their demands, because they're specifically with the healthcare workers. They're the ones who have been at the forefront during the COVID. Some other sectors, they were staying at home. The healthcare workers, they sacrificed their lives. Also, in the issue of the salary increase, this especially for coal face ones, you'll find that in terms of the salary increase, they've never matched in regard to the inflation. And we're talking about the people who are the majority taxpayers, who we do know when it comes to tax paying, it's about you build schools, you build hospitals using the taxpayers. And also it becomes unfair. I'm wearing my other cap now, also as a health professional. It becomes unfair when you see lots of money goes to the bailing out of the SOEs, money is going to elsewhere, when you've got the coal-face people who have been actually holding this country, especially during the COVID. So it's really unfair. We shouldn't dismiss. However, having said that, the constitutional right to access health services, or even the human rights aspect to access health services by the patients, by the staff, those things are not only illegal, but we cannot accept any protest that results in infringement of the people's rights. When we hear in some areas in other parts of the country that the ambulance carrying a sick child has been stopped, and they could see, and these are healthcare workers, people who are working in the health space. When you stop the ambulance, noting that there's a sick child, when you stop staff going in, because when you say, no, we allow the patients, but we won't allow the staff. Who's going to take care of the patients inside? In some other areas, parts of the country, where food was not delivered, staff couldn't, patients couldn't be able to get stuff. It cannot be, because at the end, the protest will end, and then we're all going to come back into the same house. How will you be able to view those people who would have stopped you from going to work, or who would have made a contribution in terms of the disruption? So therefore, that's why I think the Free State, the Eastern Cape, Gauteng, KZN, they did the interdiction, so that at least health services should be rendered. People can still continue their protest, but at a certain distance. For us, they've been together with the social, because it also affected the social development in other parts. I think there is a preparations of also for the interdict in some of the other areas, but I think it's still gonna be served. I'm not sure yet in terms of where and when around that. But from here, I'm just going to have a look and see and conduct oversights around that. That's how the things are. But at this stage, there are no major kind of disruptions that have yet. Nobody has died. But the issue of preventing the others not coming to work. And then lastly, Member Van Vogel, through you, Chair, it is said, and I've got a discomfort that the most areas that are being disrupted are the areas in the poorest, impoverished, where actually even without protest, the issue of the pressures in the Khayelitsha areas, Khayelitsha specifically, has always been there at the forefront. Now, when you ended up having people not being able to access, you are adding more layers, more pressures on top of the pressures that are happening. Thank you, Chair.
Thank you very much, Minister. Member Windvogel, do you wish to ask now your questions in terms of the presentation? Please proceed. Thank you.
Thank you, Chair. Chair, on slide 3, with regards to COVID-19 response by the provincial government, I'm just concerned. I saw if all of us, I hope all of us are aware about this Brackengate Hospital. The minister, they have what do you call it, a march or in front of the legislature earlier this week against the termination of their contracts. So they are. These the minister explained their role as professionals, and I see them as heroes and heroines, and I really think we owe our being to them for putting their lives in danger so we could survive COVID-19. So now, therefore, I want to propose that we really, I'm bringing it in, it's actually more a recommendation, Chair, but I want Nomonde to note it as a recommendation, is that we really need to engage in this issue, and I'm happy that the minister is present here. I know she mentioned that we are not we are not going to take other issues and answer on other issues, but because she's here, I want her to hear some of the concerns that she is probably aware of that happens while she was outside the country. So I want to propose that an urgent meeting need to be scheduled between the department and ourselves regarding this Brackengate center. Secondly, Chairperson, the HUD...
Please, you can stop there for a moment, Minister.
Okay. I'm sorry to disturb you. I was going to ask from the chair again to deviate, just to probably to respond on the Brackengate, because I have to leave now. So if I could just respond on that. I know we are deviating, but because it's there. May I?
Thank you, Minister. Thank you.
So I'm not sure whether I cut you wanted to add or must I wait? Okay. Okay. Sorry. Thanks. For the continuation, I'll just do it online, but because I have to leave. Generally, each and every year, there are contracts of the human resource for staff that end. Most of them, which is the nature of the system, the interns, when they are done, their contracts will end because they are not on permanent. The community services for medical, for pharmacy, for nurses, and all of those, they always end. That's the nature of the sector. And in most instances, you'll find that when these contracts end, of course, they'll raise them issues that we need them, which is true, but how come that we don't appoint them? So there will always be contracts that are ending. Like the interns, we take about 300 plus, they'll do their first years, they'll do their second years, and then they're out. With the MOs, they could be 100 or whatever. I mean, the community service doctors or community service nurses, and they're always in outcry, why don't you appoint us? You'll see in other provinces, like in the Eastern Cape, where originally I'm coming from, about 300 of them, where they used the previously even slept at the premier's doors throughout. That's the nature of the health system. Now, during the COVID, specifically when we started to have the CTICC, Hospital of Hope, we needed more of staff that could be able to manage the COVID. We recruited Those who have completed as far as even from other provinces, as you are aware that we were on the restrictions of the lockdown, but there was a provision so that they could come, most of them for the city ICC. And then when it closed, we continue with the contracts, and this was from the COVID money that was provided by the provincial treasury. Chair, the president did come when Western Cape was dubbed the epicenter when we were opening the Bracken Gate, and there were promises that there was going to be money that will follow, but there was never money followed. But let's leave that part of that. So the provincial treasury used Section 25 of the Finance Management Act to rob Paul, to pay Pauline, to take money from elsewhere in order for us to get that money. So part of that money was the contracts. In addition to that, in Metro, probably the chair, a member will recall, we had two song center in Khayelitsha as part of also another a field hospital. We ended up having Bracken Gate outside the Metro. We had Sonstral, which was a TB hospital. Also, it became part of the field hospital to accommodate the Vescas and also the Winelands. We had Haricomay, which is also a TB hospital, but we had the infrastructure to accommodate the Garden Route and the Central Karoo as a field hospital. In other hospitals, we converted, for example, in Vredendal Hospital, we converted a boiler room and had it ward for the COVID. In Hermanas Hospital, we changed the underground storeroom and converted it to be a COVID ward. In Stellenbosch, the training room that was meant for the old nurses' home, we converted also for the COVID hospital. What I'm trying to highlight is not only Bracken Gate. We had it everywhere during the COVID, using the COVID money that I appropriated here in regard to that. Everyone knows now that we don't have much of the COVID. We haven't seen many of the admissions or death. Therefore, in as much as that for the Bracken Gate, the list still continues. It cannot continue as a COVID hospital. Also, the contracts, Chair, I have to NB this. The contracts were never terminated. The contracts were ending 31st March. They were not terminated. So the contracts that were signed when the people took up the job were ending 31st March. So during the process, because now there were not much of the COVID in the process, one could just terminate prematurely those contracts during 2022 and say that we don't have much COVID. Bracken Gate now, just go. Who could have done that? But instead, it was about continue with the contracts as it was until 31st of March. But in the process, the staff could do something else when now it was being converted to transitional hospital, which is what we are doing actually even in other areas. For example, in Ceres Hospital, we have a transitional, the Netcare hospital that we bought, which is now going to be a transitional hospital or facility. So we're having all of those. Transitional, it means that it could be a step up or a step down, meaning in the case of the Bracken Gate, it's about the patients from Khayelitsha, Helderberg, Mitchell's Plain, and all of those who would have been probably admitted and have been seen by the specialists, but they are still not ready to go home as yet, but they are ready to be out of the specialized kind of a system so that they can recuperate. So they are being there and thus making beds available in those wards. So instead of early terminating their contracts because there isn't much COVID, we said continue, and they should be able to establish this so that when the COVID money is done, which is, there's no COVID now, money now, it's about, it becomes a transitional hospital. So they were never terminated, the contracts ended. Now, the Bracken Gate was a 330 hospital, but there's no way that you can have a transitional hospital of 330. And also there's no COVID money now. So what we said was about you reduce the number of beds, I think it's 100 and something, 70, 68, or I don't know specifics, but you reduce the number of beds, you make a transitional hospital, and then you advertise now posts, because out of those 200 and something, let's say nurses, they will never be able to appoint all of them. These are only for Brackengate. Remember, in others, there are also contracts that are ending. Probably, I think about 800 and something in total of the whole contracts related to the COVID. So there's no way you can absorb them. Plus also there's no way you can put all those staff back to do transitional. And also some of the staff were seconded there, not necessarily they were part of the permanent staff, but they were working there in that space. So therefore now it's going back to where things were, but now advertise for transitional hospital. Anyone's in that whatever can apply, because you cannot. Because once you start to say we absorb, it means we have to absorb all of them everywhere, and yet there's no new money. When I do the appropriation or the budgeting, you'll see how we are losing 1.5 billion for this year of the budget because of the decrease in equitable share and also decrease in conditional grants. And we have got the surgical backlogs and everything. So it's not true that the contracts are terminated. It's not true that Brackengate is closed, but it's from being COVID hospital to the intermediate. And we thank the staff of what they've been doing, being on the forefront and everything that they have done. But we cannot just absorb them throughout. We don't have money. And also it's about, for fairness and justice, it means everyone, including them, they need to apply. But I do understand that it cannot be that we train people, because these people take 4 years to train a nurse, 7 plus 3, 10 years to train a doctor. And the people now ended up that they won't have a job because the economy of their country doesn't allow us to appoint as much as we can. And there are even many doctors and everyone, not only for this COVID, who are unemployed because we can't absorb them, and yet we need them. But there's no money, unfortunately. I have to leave. Thank you very much.
Thank you, Minister. Much appreciated. Thank you, and go well.
I'll answer online.
Thank you, Minister.
Can I finish my last two questions, Chair?
Please do.
Yeah. Chairperson, on slide 4 and 5, if the department can give us an explanation of what partial achieve means. And for those that are partial achieved, what is the likelihood of being improved to be fully achieved? Then secondly, Chair, on slide 6, 7, with regards to the targets for regional hospitals, I must commend the department because I know the good performance there. But I want to ask the following. On slide 7, I'd like to know what are the reasons for the poor performance in the second target for program 5, the central hospitals. Thanks, Chair.
Thank you. Thank you, Member Windvogel. Next question is from Member Fry.
Thank you, Chair. If you indulge me, I've got 4 quick questions and 1 comment. On slide 9, the SAC 1, the reporting of incidents to provincial, district and sub-district officers after hours and weekends is challenging because there are no staff on duty. Surely we can have standby staff over the weekend for this, or is there no money for employment of staff? I mean, you know, it's not in context. As I understand, it's head office staff or district office staff. So surely someone can be on standby for that. Slide 11. Slide 11. The teenage pregnancies, 8,000 over the 3 quarters is very concerning. It's very concerning to hear that there are 8,000 cases of teenage pregnancies over 3 quarters in this province. And what would you, what awareness programs are we running to curb the scourge of, not the scourge, to curb the issue of teenage pregnancy? Slide 34. average length of stay. Sorry. Yeah, slide 34, average length of stay. What is the length of stay for mental health patients, or do you not measure that? Because in the report, in the presentation, you said trauma and mental health pressures remain high and increasing, and we've been on cluster visits to Plettenberg Bay as well as Knysna, if the members can help me. Plettenberg Bay as well as Knysna, and both of those hospitals have noted that there's a pressure on mental health patients and average length of stay. So, yeah. And then my last question is on page on slide 37 about the EMS services. How is the attacks on ambulances affecting EMS response times and EMS response rates to that? And what is the department doing to curb that? Thank you.
You had a comment as well, you said? Or have you commented?
Question. That's a question.
Okay,
Thank you.
Thank you. Next then is member Klaas. Sorry, Chief Director, is that okay if we take a couple of questions at a time? Thank you. Member Klaas.
Ngosi mhlali ngaphambili. Xa into endibethayo uba uLanto uminister uye wahamba. Ndingavuya kakhulu uminister uba unoyimamela kamandi uyasithetha isiXhosa, ndifuna uthetha kanye naye. Ayonithi ngithethe nabanye abantu kamandi ulwimi lakhe. Uminister mabe bayivule inyoba yobhatala abantu, makangasixeleli uba soloko akho mali. Iba khona imali elahlekayo esingayazi uba ilahlwa yintoni kwezinye ii-department, but kule yakhe akho ilahlekayo, but ayikho neyonceda abantu. Mabathi xa behlala bona bacele kunyuswe imali ibe ninzi, at least le ayibeki le yeyogqirha, yeyobhatala oonesi. Cela ke kula mpendulo yakhe yokuqala beyibuziwe ye-national strike.
Member Klaas, sorry. I wish to, sorry for interrupting you. Can we get questions on the report that was delivered, please? Thank you.
Ya ndizawuza phaa kodwa uqalile wayifuna ithuba loba makabuzwe laa mibuzo, wayiphendula wayahamba. Nam bendizawufuna kaloku ucela loo mibuzo kodwa khange ndilinike ithuba. So yilaa nto ke ndithi ke ndizaliphendula elo thuba. Enkosi, ndiyacela nam ndinike elaa thuba ngoba ubuye wabanika bona uba mabaphendule. Waphendula ke nguminister. Ngoku mna nje bendimthi nje uba ngaba makayeke into yobusixelela, makacele imali ifakwe ibe ninzi kuzoqashwa. Ndiza kule ke yesi slide uyifunayo, ndoda enkulu. Kwabasebhegeti andifuna uphosisa sisi. Mabacele imali ibe ninzi. Xa sekukhona abantu abasebenzayo, mabafuna imali ingene phaa. Ziyalahleka imali. At least akho imali izawulahleka.
Member Klaas.
Ukuza ke kulena. Oh, I'm done with talking about, I'm coming to the
Member
point.
Klaas, please, can we stick to the program that we have at hand and stick to the report? Thank you very much. The Minister has explained, and it is the budget vote very shortly. I'm sure you will have the opportunity to address the issues you are addressing now on that occasion. Thank you.
Yeah, babekhona tata, babekhona. Ndizawungena ke kulaa nto ziyabizwa ngezi slide ezi. Eyam ibile kakhulu yabantwana aba 8,000 abafumana abantwana. And nokuva kakhulu uba uthethe nangengxaki yekhondom uba funeke ziyothestwa uba ingaba ngaba zirayithi na, uba ngaba zingasetyenziswa. Elo thuba ke leli ngathi kuwe liye lenza uba abantwana aba 8,000 babe nabantwana. Mna benocela ubuza ke ngokuba yintoni enisawusenzela yona okanye yintoni enisibonisa uba ninoyenza unqanda uba ningafikeleli kule 8,000 yabantwana. Kwalapha ikhona le NDOH. Mna bendifuna sive kakuhle uba ngaba ingaba bona baye ngokulibaziseka uba ngaba mabafumanise uba ngaba yintoni ingxaki nezi condom. Emva koko bebuyile babuye bathi yintoni ingxaki, and okwesibini bathi yintoni isisombululo sayo. Enkosi.
Thank you, Member Klaas, and thank you to the translator. For this round, the next question is from Member Baku Vos.
Thank you very much, Chairperson. Chairperson, I have only two questions with regard to patient safety. Is there any additional budget for security that has been allocated to facilities following the fatal shooting incident at Somerset Hospital? And my second question, that one is on slide 10, and the second question is, I would like to know what are the challenges regarding condoms distribution. And the last one, in slide 38, yeah, it's slide 38. I see that there is a lack of performance when it comes to the suppliers. I would like to know what the measures that will be put on to reduce this challenge, and what are you going to do when you are addressing this contract management regarding these suppliers' performance? And I want to know about the application of penalties and escalation of endowment where are appropriate. Can you please explain more about that or elaborate on that? Thank you very much.
Thank you, Member Baku Vos. Member Buns, I see you. I will respond to you once we have had answers or replies to this round of questions. Chief Director Nkosi, please. Thank you.
Thank you very much, Chair, and to the members for the questions. I will try to respond to them as much as possible, and if there are any that I might need my colleague on the screen to respond to, I will also indicate as such. And I will beg the members' indulgence to please indicate if I have missed one when I was jotting them down. So if we start with the first questions from Honourable Member Van Vogel in respect to just the explanation of the targets across the three categories. I think the achieved targets is clear in terms of it's the target and we have achieved it. But in terms of achieving it, we have a range. We take from a range of 95% achievement and above to have achieved that target, because in the nature of what we do in health services, it's not really so much an absolute number where if, for instance, you would say, I wanted to issue 1 million condoms. If you issue 999,000, you would then say you have underperformed. But if it's in the range that at least 95% of the target, because you are working on estimates related to the population, we don't work on absolute numbers of things. So in terms of us then also working on whether we have achieved or not achieved these targets, we work on ranges in that way. So any target that we have achieved 95% and above, we take that to be a target that has been achieved. And partial achievement is at least 50% of what we have intended to achieve up to 95. And anything for which we have not achieved 50% of the effort of what we have intended, then we regard that as not achieved of our performance, because in some cases, whether it is 1 or 2 or 3, it's not, it doesn't give that absolute, assurance. Hence, then we work on a range as such. I hope that answers the question, member, in terms of at least the categorization between the three groups. Then your next question was in relation to central hospitals and not tertiary hospitals. Okay, so in central hospitals, the underachievement in respect of that SEC1 incidents. it is actually what we had reflected in our slide 8, honorable member, in relation to the increase in the numbers of cases that had to be reported, because we've now changed the definition, or rather the definition has been changed to include other categories. So the fact that now there was a lot more cases to be reported, and having to report them within the 24-hour period. So we were not able to achieve that 24-hour period, partly because there were more cases to be reported, but also there was the issue that over the weekends, of which I'm going to deal with that question when I get to the honorable member, we are not able to report the cases as such, but also there are issues with us having to report on multiple platforms. It's something that we are working on with our IT team to help us to have one central repository where if you have reported in this database, whether you must also report on another platform, you can use through information technology systems then to record that we have reported this case, and you can reflect it on the multiple platforms that require that. So there was nothing specific in the tertiary hospitals in the central hospitals that has resulted in the underperformance, other than what we had already reflected in slide 8 as well as on slide 9, honorable member. Then if I could come to, I think those were the two questions in response to Honorable Van Vogel, and then the honorable member around the issue of us looking at standby allowance for this. Honorable member, from a financial resource point of view, and the fact that these cases can or cannot happen, I think the cost benefit in that regard would require us to look for alternatives, probably from an IT perspective, to have a way of logging and reporting the calls as and when they happen, so that even when people are not in office over the weekend, they can come back to looking and reflecting on the cases that have been reported, because these are office-based administrative staff, issues of getting them on standby and having to pay them standby allowances are things that would probably not pass the test with the Department of Public Service and Administration. So we would be looking at other alternative means within the use of technology to assist us to be able to make sure that the cases are reported and can be logged and registered as having been reported, even to people that are off-site and are not at work at that particular point in time. But it's a matter that we are looking at, and we would be able to see to it that we are addressing that to ensure that we ultimately meet our compliance. The issue of teenage pregnancies, as we had indicated, it is a concern for us also. And it is something that we are really, as the department, wanting to work with the whole of government and society to address. Because when it comes to us as health services, we support with preventative measures in terms of ensuring that condoms are available and all of those things. But in our system, we tend to also find the problem it presents to us when it has already happened. So there are also multiple players that in the system ought to assist us to make sure that we reach the children, because we provide the services in our facilities. The issues of stigma, that the neighbors will see you when you go to the health facility for contraceptive and all of that, and you are perceived to be promiscuous or, you know, a not behaving young person. Those are some of the issues of stigma that still make the issues of access to contraceptives and all of those things a challenge for young people. We work with the Department of Health because we need to find them where they are at, not in health facilities, because in health facilities they can or cannot come, but in places where we find them, in schools, in places of recreation and all of that, those are the partners then that we are working with to ensure that we increase that awareness in those places where they find themselves, and also providing access to the issues of condoms in those sites for the colleagues to be able to for the young people to be able to proactively prevent issues of teenage pregnancies. So the average length of stay for mental hospitals, my colleague Leslie, I will ask her to reflect on that. Obviously, the mental hospitals on their own would not have been included in this because the patients that are in mental hospitals stay for much longer than a normal patient. There are those that must go though for psychiatric observation in the district hospital for a 72-hour observation. Those would be reflected and included within the statistics that we have reflected in the district hospitals and probably in the regional hospitals as well. But I will ask my colleague Leslie, when I've gone through the rest of these, to mop up in respect of the average length of stay for the mental health hospitals, whether we have reflected on that and whether it is actually an indicator that we reflect on our annual performance plan. Then on your question, Honorable Member, around the attacks to EMS staff, indeed, attacks to EMS staff do impact on the turnaround times, because if you reflect on our slide 37, we indicate there that sometimes the access to red zone areas results in delays in turnaround times, because to go to those areas you also need to have the escort by South African Police Service, and if we are not able to get availability of subs vehicles and things, then you tend to find that the response time to those places affects. We do work obviously with those multi-sectoral stakeholders, the community, police forums, SAPS, and all related stakeholders to really work on those issues of at least allowing access for our emergency medical services teams to be able to access patients, which will ultimately then improve on the turnaround times. But again, it's something that is beyond just us as the department and requires us to work with other partners within government, but with society also through the community forums to ensure that at least we are able to be provided access to those facilities. Then member class, I'm not sure if Minister is back online yet, maybe to respond to the issue of the opportunity to appoint the staff and to find ways and means. But as somebody who supports her in the department from a strategy point of view, and knowing the work that we do with the head of department and the chief financial officer, we never miss out on the opportunity to make sure that we present our case for more resources to the provincial treasury, to explain our plight in terms of saying how the department is finding itself under pressure and therefore the need for more resources. Unfortunately, then, depending on what resources they are able to give to the department, we are able to understand how much more resources can we appoint. We have to be in compliance with the Public Finance Management Act that allows us not to overspend the appropriated funds within the department. So to the extent that we have been appropriated this much, we have to live within this much. We always, at every opportunity, go to the treasurer to ask for more funds because we see the pressure on the ground. We see the impact of it on our health workforce. But unfortunately, to the extent that the resources are constrained and will continue to be constrained, we will only be able to cut our cloth according to the pattern in terms of the amount of money that has been allocated to us. The issue that you raised, Honourable Member, around the delays by SAPS in terms of passing the quality control test for condoms. Obviously, we raise those things with the National Department of Health because those condoms pass through. They come from the National Department of Health through the national RT contracts, then they go through the Bureau of Standards, and then they come to us once they've been certified. So we raise and escalate those issues for urgent attention and resolution between the National Department of Health and SAPS, and we then really rely on them to assist us to fast track that process. So it is something that we do raise and look to the colleagues then to assist us with urgent resolution of that. If I then come to Honorable Baku Force issue around the budget for security at Somerset, The fiscal environment, as I've indicated, Honourable Member, is getting bleak and bleak by the day. Minister has indicated that we are staring down the barrel of a shortfall in terms of the budget that we have from one year to the next. So we work within what we have. We note the issues of security threats and concerns in our facilities. We see how within existing resources, using technology, working with the whole of government and society to keep our environment safe, see how we can then contribute directly and indirectly to improving staff security. But I cannot guarantee that there would be any additional budgets directed to address this security issue at Somerset, given that the port itself would not have increased. So for me, that would then be our response in respect to the budget for security. But we would then be looking to say, how do we strengthen the existing security within the facility? The issue of condom distribution, I think we have responded to. It's something that we continually monitor and look at. On supplier challenges, we raise this with National, who has got the RT contracts. When we are experiencing supplier disruption challenges, bring penalties to the extent that those penalties are provided for within the contracts that we have. When we escalate, even suppliers are possibly blacklisted on the database so that we know that those are not suppliers that can be used going forward. And as part of contracts management, we also engage with those suppliers to constantly to understand where the bottlenecks are and whether there are alternatives to how we can address this. So we do also engage in those supplier relations with suppliers, because in the space of pharmaceuticals, these things are provided, they are standing things that we would be requiring from service providers. So we build relationships with them also over time so that we understand where the challenges are at and whether then there are any possibilities that we can be able to mitigate the risks. But largely, within the department itself, we try to manage the impact of stock outages such that we do not then feel the adverse impact of that stock unavailability across the platform. With your permission, Chair, I will then ask Leslie Shand to add on specifically the issue of the ELOS in the for mental hospitals and any other additional matter that I might have then left out, Chair. Thank you.
Thank you. My apologies. I don't know what Leslie's surname is, but...
Oh, Leslie Shand. My apologies, Chair.
Not at all. She's welcome to proceed. Thank you.
Thank you, Chair. So we do have data on mental health admissions and the length of stay. It's not something that we report on in our annual report, but the department is blessed to have a very rich set of data collected by our systems. Just having a quick look at the data. In our psychiatric hospitals, our length of stay on average is around 100 days. But in our acute hospitals, where Ms. Nkosi was mentioning the 72-hour assessment period and admissions from that, we have a average length of stay there of 12 days. That's across our district, regional and central hospitals. Comparing that to on what we're currently seeing in those facilities in general, it's about 3 times what the average person's length of stay would be in our acute hospitals. So it is a lengthy treatment period in those hospitals. And of course, many of those patients will then end up in our psychiatric hospitals. Perhaps if I can just add on to what Ms. Nkosi said about supply contracts. In the instance where we have suppliers that can't supply, we obtain alternative suppliers for that consumable, and any additional price that we pay is charged to the original supplier. So there's no public funds used for poor supplier performance. Thank you very much.
Thank you, Ms. Shand. Appreciation. Shall we go to the next round of questions then? Member Bunce, and then Member Bakker Vos, Member Windvogel, and Member Klaas. Member Bunce.
Thank you, Chair. My first question is on slide 38. Can we get more details on pharmaceutical stock out as well as vacancies as mentioned in the slide? What is the prevalence of these? And then my second question, Chair, is on slide 40. Slide 40 speaks of workload pressures, exactly in the light slide. What are the causes and what hospitals are affected? I understand that we got quite an intense report now from the minister with regards to Brackengate, but my question also there would be, we understand the response that says that the contracts of Brackengate staff came to end. But as we can read from this slide in this representation is that workloads, they are constantly there. Does the department have a strategy to deal with these unemployment rates, in fact, or contracts that are coming to an end, etc.? Because minister says annually, every year we go through these things. Are we just accepting as a department that, okay, next year there are going to be more doctors and nurses on the street? They are coming to 7 Wheel Street to come and have a march? Or how are we addressing this? I also hear them saying that we are asking for more and more funds, but the reality now is that the need is there. Do we have a strategy? Do we sit down as a department and try and find a way to help us as a department, because the workload remains with us, and also addressing the need of the doctors and the nurses that are outside? My last question, Chair, would be on, I forgot the slide, but it was speaking of SEC 1, where the presenter was saying that more cases are registered now under SEC 1's hands. The figures are going up. For my own interest in wanting to understand, what are the normal cases registered under SEC 1 and what are the new ones that were added to make SEC 1 to be going a bit up, the stats to go further up? If I can just get clarity on that one, that will be all my questions for now. Thank you, Chair.
Thank you, Ms. Bunce. Member Bakker Vos.
Thank you, Chairperson. My question is on slide 15. I want to know what is the prevalence of HIV in the age group of 15 to 24 in the province? Do we have a breakdown of this per race, gender, and district? And the second one, with regards to the targets of ART, adults remain in care rate on 12 months. Why is the department always struggling with this target? What are the issues with this target and what strategies are in place to address this challenge? Thank you very much, President.
Thank you, Member. Member Windvogel. Your microphone, please.
Thank you, Chair. Mine is on page 26. I'm just checking my page now. Yeah, mine is on page 26, child death. There was a under 5 years, yeah. Yeah. Page 26 to page 29. Can the department please tell us more about the child fatality and fatality targets and what is happening there? And how does this affect the overall child mortality in the province? And how many children have died in the province between these 3 quarters? And then on slide 32, can the department also tell us more about these deaths of children and what are the causes? Then lastly, Chair, on slide 33, I just want to check with the department, how does the bed shortages affect the average length of stay in bed utilization rate? And can we get an overview of beds and staff shortages in all these hospitals? Thank you, Chair. Then just to add a follow-up on what Member Frey asked in terms of EMS. I couldn't get clarity. Are you saying you reach your targets there? Because it's a concern, because according to me, EMS, the services, the turnaround time, it's poor. It can't be that you reach your target. You can correct me if I understand you wrong, but it can't be that you reach your target with EMS. It's one of the services that we failed our people badly. And then I want to know, is there budgeted for more ambulances or for the new book here to at least reach our target? Thanks, Chair.
Thank you, Member Witvogel. Member Klaas.
Thank you, Chair. My first question is number 14. When there is a sentence said that sterilization have not fully recovered. So when you said sterilization has not fully recovered, what does it mean? Because you said you recovered to pre-COVID numbers. So in other words, we don't know that you have to decide to stop it or whatsoever. That is why I want to understand on that about sterilization. And then in page 15, you put ages there, and then you said there's achieved and not achieved. But what I see there, the most achieved or the most not achieved, it's where they are on TB. And the TB, it's old. It's a disease before HIV, it's a disease before COVID. And yet, for this information, it says that there are more deaths in TB, if I'm correctly listening to that. That is one, I want a clarity on that. And then you come to page 29. Children under 5 years severe acute malnutrition case fatality rate. I want to understand on that, do they don't get food? Because malnutrition is done when you don't eat. So I want just to understand on that. Thank you.
Thank you, Member Klaas. Chief Director Nkosi, please.
Thank you again, Chair, and to the members. And I will also again ask for Ms. Shand to pick up on those responses that I will have not provided. So in terms of Member Barnes' questions on slide 38, more details on the stock outs, I think there we can, as much as we have met the target, but we can provide the details to the member. We don't have them with us here in our record of those stock items that were out of stock for the reporting period. That is information that we have at our disposal, which we can provide, but it is indeed a target that we had met as the department in terms of the range, because it is above 95%. So 96.8% of our pharmaceutical stock was available, and therefore we were able to service our clients in that regard. So we could then provide more details to satisfy the member in respect of that. Then on slide 40, the details on the work pressures. The work pressures, workload pressures, Honourable Member, are on a slide. We had indicated them on slide 35 and also on slide 36 across the entire platform, both in our district hospitals, in our regional hospitals, central and tertiary hospitals. We are experiencing pressure on the platform because exactly of the things that I had indicated in my context earlier, that since the 33 months of COVID, we find that patients that come to the facilities, because they have not been accessing care for some time during periods of lockdown and such, they are now presenting much more sicker in our health facilities. So it is now it's taking them longer now to be in facilities, and they present with much more complicated cases, which require that now clinicians take more time to give care to them, which all boils down to now the platform being under pressure. Mostly trauma and mental health are driving the pressure in the hospital platform. But again, those details, if the member would wish us to provide her with more detail to say in our hospitals, where do we experience this most severe trauma and mental health pressure, we have got that detail that the department can share. I think then the next question from the member is actually relating to the earlier issue around the strategy then to absorb or to appoint more doctors and nurses in light of the pressures that we are experiencing and professing here. And I think the issue really, as I had indicated earlier on, boils down to whether we have the resources to appoint the staff members. It is a true fact that we need them because the pressures on the ground are showing that we need them. During COVID, national and the provincial treasury provided us resources to add resources to the platform, which we were grateful for. But unfortunately now, because COVID has subsided, notwithstanding that the pressures are actually higher than during COVID, then the money has been withdrawn from us, and the priorities for the country are now on elsewhere, on issues of security and other things. As a result, the COVID money is no longer in our baseline. Therefore, as much as we would like to take on those colleagues, without the resources to be able to appoint them, unfortunately, we become hamstrung as the department, and as and when within our available resources we can be able to appoint the colleagues, we continue to snatch them there and then, to snatch them and appoint them. But unfortunately, until we can really be resourced from a budget point of view, satisfactorily to be able to appoint all of these staff members, then unfortunately our hands are tied, because we still have to make sure that we remain within the available resources that have been allocated to us. It is a national phenomenon, the issue of staff that are out there without employment, yet the platform, not just in the Western Cape, across the country, is burning. So it is an issue that we also continue to engage with beyond just the Western Cape Department of Health, also at national level, to see that the resources are still being prioritized towards health. And then when those discussions bear fruit, only then we would be able to say we can comprehensively address the issue of the staff members that find themselves on the street without work, whereas we continue to experience pressure as the department. So the member has also asked about SEC1 cases, to understand what are the normal things that we report under SEC1, and what are these new cases that we have brought that have resulted in the exponential increase. Issues like patient falls or any adverse event that has happened to a patient that would then be reflected as a SEC1 based on its severity. But the main addition now that has come onto the definition of SEC1 is patients that abscond, that just get run away or leave the facility without being formally discharged. Those abscondments are a new addition. They were not previously categorized as SAC1 cases, and now that inclusion of them within the definition has then now increased the number of cases as we are seeing reflected on our statistics in the presentation that we have just presented. In terms of HIV prevalence, Honorable Baku Force, we have that detail. Unfortunately, we don't have it in the presentation with us now here, but it is information that we can definitely provide to yourself in terms of the HIV prevalence and broken down by sub-district or sub-region, and to the lowest aggregated available information. We can share that information with the committee as the department, but unfortunately we do not have it with us at the moment. You have spoken to the issue of the 15 to 24-year-old and the challenge with regards to us meeting that target. I'm going to ask Ms. Shand, Chair, at the end of me responding to these questions to also add, maybe in respect of the specific challenges that we are experiencing in relation to that category of clients and that specific indicator. And then coming to Member Van Vogel, it was the child under 5 case fatalities. Here, really the major impact has really been the issue of the pediatric surge that we have had earlier on, as well as the measles and the pertussis that have affected the child deaths in the under 5 categories in the year that we are under review. We have had those 2 outbreaks in the country and nationally as well, and that has then also impacted on our statistics in the province. But Ms. Shen can also expand on that indicator for us, Ms. Shen, if we could do that when you speaking to the question that Honorable Baku Force has also raised. Then coming to page 33, Member Van Vogel, on your question on the bed shortages and how those affect the bed utilization rate. Indeed, when you have got bed shortages, you find that your utilization rate increases, because then you are having a bigger number of people that are utilizing your beds. You've got more pressure, and therefore you would find that your utilization is even beyond 100% utilization of your existing beds, where you are then finding in some of our hospitals the targets, for instance, on the district hospitals, our utilization is at 107%. On the regional hospitals, no, the regional hospitals are below 100, but the central hospitals as well as the tertiary hospitals. So the impact of the staff shortages is that it increases then the utilization of our beds in the platform. In response to your question on EMS, indeed on EMS we have not met the targets in respect of our response on under 15 minutes, under 30 minutes, and under 60 minutes in EMS urban as well as in rural. So in my response, I wasn't indicating that we had met that target. We have not met it. And the issue of attacks of staff in red zone areas also impacts, because it results in us taking longer to reach those clients, whether it's in rural or in urban, and therefore then resulting in longer turnaround times. The issue of whether we have got now additional budget to meet our target for next year, again, we are going to have the appropriation bill in next week. We will find that our budget is less than what we had in the previous year, so we are not seeing additional resources onto the current baseline. But we will obviously look at all measures that we can put in place to improve the turnaround times. Amongst other things, we have also had a private vendor contract, which we are going to put in place in the first quarter of 23-24 to also bring the private ambulances to support us in terms of increasing the fleet that we've got on the road. So we are going to be looking at that and other measures to make sure that we improve on turnaround times. If you look at the issue, for instance, that we raise of red zones, if we can have an effort between SAPs, community forums to lessen the impact of us having to wait before getting into red zones, those things without adding resources would help us to improve our turnaround times. So also working with the whole of government and other sectors and partners to help us, especially in those high-risk areas, would also just help us to improve the turnaround times in those particular areas. Then if I come to a member Class's question on page 14, he's asking about the sterilizations. On sterilization, the issue that we are raising there is that they are also an effective contribution towards addressing issues of teenage pregnancies. But at the moment, we are not doing the sterilizations at the levels that we were doing before COVID. It's a concern for us because we are still below the level that we should. And it's not that there is no need for this, but we have got much more sicker patients. So in terms of triaging patients for surgeries, we have those that are now presenting much more sicker. And in terms of prioritization, you start with that person whose life is much more at risk. And then you tend to find that something like this then becomes it becomes the next thing on the list and not the first thing. So it is something that we are working on and hope we can deal with those acute surgery backlogs so that we can bring the non-acute surgeries, but which are also critical to stop the runaway teenage pregnancy that we are seeing. The issue that you raise on TB indicators that are the ones that we are not achieving, it's something that continues to concern us as the department because indeed our outcomes on TB as the province are not at the level where we would like them to be at. We continue again to work with partners in the whole of government and whole of society to ensure adherence because it's these issues of ensuring that patients then remain on treatment and are not lost to follow up, and issues like working with patients themselves to also help us by giving us accurate contact detailed information so that when we need to follow them up for treatment, we are able to reach them. Also, the migration of clients because of socio-economic factors, you find that by the time you follow them up, they are at Basemakaya, and by the time you need them, so it's things that we need to be working on to make sure that we really improve on our management of TB and with our efforts as the department, but also working with the clients on their side and other partners that assist us in the space, like the NPOs that help us with also tracing patients that are lost to follow up. The last point I think you had raised was around severe acute malnutrition. Indeed, children that present with severe acute malnutrition are children that have not been fed, whether breastfed or given appropriate nutrition at home. So they present in the health facilities sicker. So it is something that we find that it is a direct consequence of the impact of COVID-19 because people have lost livelihoods. So those that had money to buy food now cannot buy food. And by the time then they, and therefore that has an impact on the children. And when they bring them to facilities, those are now, the children come in sicker and needing more care and in most cases also dying. So again, there we are partnering with the relevant departments, like your Department of Social Development, to have the relevant interventions in the homes so that the children are attended in the homes and are not sick and presenting sick at the health facility. So it's something that has to happen also in the space outside where we are at as the department. But it is something that is concerning us, and we have picked up that it is a consequence mostly of that impact, socio-economic impact that COVID-19 has had on our society overall. And Chair, with your permission, then if Ms. Shen can then just mop out those remaining questions. Thank you, Chair.
Thank you, Chief Director. Ms. Shand.
Thank you, Chair. I think the ones Ms. Nkosi wanted me to cover was the HIV prevalence, the child art remaining in care and viral load, and then the child fatality rate. If I missed anything, please remind me. The HIV prevalence, 15 to 24 years, is sorry, I'm just getting there. We're currently on target with that, but it is a challenge. The rate currently for this year is 1.2%, which is down from previous financial years, which is a positive thing. And so we continue to work on testing, and we've increased our testing for this year to pick up more cases. During COVID, there was a lower rate of testing and we didn't necessarily find all cases, but we have increased it this year and we're getting better coverage. So I think we have improved the identification of positive cases. In terms of the art child, we're on target in terms of the number of children remaining in care. At around 60%, but that is low. You would obviously want to keep all children in care at 12 months. And that together with the viral load suppression rate is impacted by socioeconomic situation. Some of our clients and patients are very migratory and move around the country, and often we have instances where they don't necessarily link to care, perhaps when they go to another province or to another facility or area in the province. And this obviously means that we lose them, that they can't contact them. The contact details perhaps are not available or still accurate, and have changed, and then we're not unable to trace them. And once they have left our care, obviously the viral loads, and if they're not on their treatment, the viral loads start increasing again. And so when we eventually do pick them up, or they come back into care, the viral loads are lower, higher than we would like. And this is an ongoing challenge, tracing our patients and keeping them in contact. We utilize the community health workers to try and trace the patients in the community and bring them back into care, but that's not always possible if they have left the province. In terms of child fatality, we currently have for this year, sorry, just want to get the exact number for you. Under fives, we've had 874 deaths in our facilities. There may have been deaths in the communities and in the private sector that haven't been reported to us, but those are the ones that have died in the first 3 months of this financial year. Ms. Nkosi, does that address everything that was required?
Yes, I think you have covered, through you, Chair. Yes, I think you've covered, Ms. Shand. Thank you.
Thank you, Ms. Shand. Members, are there more questions? Member Plato, Member Windvogel, in that order, please.
Chairperson, thank you very much, and I welcome the presentation. Quite comprehensive with lots of very important detailed information. Two soft issues. I think the reporting of incidents over weekends, I think it should not need to be a challenge. I think the department needs to put necessary structures in place to deal with it, but thanks for bringing it under our attention. The next one as well, a backlog of capturing a TBH. We are now aware of it, but it is another soft issue the department should deal with. I think for me, very importantly, and it's a shocker, the teenage pregnancy rate, and I think that is where the Department of Education and Social Development also need to step in to play their roles as well. Our advocacy programs as government as a whole, I think we need to up that, and we need to do something much more comprehensive about that. I would love to understand and love to know the 10 years old, who's the partners. Is it older men? Because that is my understanding. It is what my research shows, but it is also over 20 years old. And there's laws in this country prohibit men from having intercourse with youngsters under the age, I think it's under the age of 16 years old. How can our justice system, how can our educational system, how can our social development system and health system allow things like that to continue? But also our community structures. What is our advocacy with regard to our community structures out there to deal with these problems and to address it? 8,000 plus girls is an awful lot. And our legal justice cluster allow that to happen. So there needs to be talks with the men and that sort of thing, but cases at police, is cases opened? How can a mother allow a 10-year-old daughter coming home and detect, mom detect she's pregnant? You leave it as that, it's normal. What society allow it and we allow it and that sort of a thing. We cannot allow things like that to happen, and that is why I'm so glad that that it is part of this report for us to note our community forums, other structures, our advocacy in general. I think leave a lot to desire. We need to up that. And then on page 13, you mentioned the deliveries under 20 years is at as high as 12%. But I have said enough about that. That needs to be dealt with. Then the piece on page 22, your PCR positive birth rate, and it could be migration, it could be other issues, it could be poverty and that sort of thing. But that in itself is very, very high. That also needs to be addressed comprehensively. And what the lady just mentioned, and I think Honourable Klaas mentioned it, Honourable Windvogel mentioned it, from page 26 to page 29 for me is also another shocker. 874 deaths. Is 874 deaths far too many. It's far too high. Your target rate is only 38%, but I understand it's not an issue for the Department of Health to deal with on its own alone. Other entities, as I've raised, social development, education needs to step in and needs to help to address these problems. But what I can't understand is the Department of Social Development avails such a lot of food aid to many communities, to many NGOs. What is the role of NGOs in this regard? How is food aid distributed? Who receive the food aid? Are the correct people receiving the food aid, those that is in need of the food aid? That we will have to look at. And the under 5 years acute malnutrition rate, the fatality rate is on page 27 is only is 14.6%, but it's 14.6% far too high. The page 28 achieve rate only 30%. Can't be. And I think these categories from page 26 to page 29 needs more in-depth scrutiny, and the other departments also needs to step in to help to address this. And again, if you are correct in pointing out to food, I can understand poverty. I think you're correct in doing that. unemployment, that sort of thing. But again, it seems to me these mothers and families don't know where to go to find food. And we cannot allow as a government in our backyard, on our doorstep, that so many children die as a result of malnutrition. I want to make the point as the chairperson of the Social Development Standing Committee chairperson, that it should become one of our recommendations as well. We need to look at what else can we do as social development to address these issues. And I know there's food banks in the Western Cape, a Western Cape Government Food Bank, Western Cape whatever, other food banks and that sort of thing. Maybe we need to get the food banks in to look at the distribution, but it seems to me that the people in need of the food aid don't receive the food aid, and that is my final critical point, Chairperson, I want to bring across, that needs the necessary serious attention. Thank you very much.
Thank you, Member Plato. Member Windvogel.
Baie dankie, Chairperson. Chair, Member Plato actually covered me, let me say, partly. But I just want to check with the department chairperson in terms of do they have a system in place where they know exactly, because the presentation is speaking in general in the province. If we look at specifically at nutrition, where you are saying kids because they are not getting the right type of food or whatever the circumstances was. Do you have a system in place to see, okay, in Khayelitsha, we have a lot of children with the same problem, and then we do type of intervention into that area. Do you have such type of system? I know the minister loves to say where numbers, you must bring numbers where, I'm not sure, do you have? So that's my question, Chair. Then secondly, Chairperson, the presenter also mentioned about the harvesting season. I just wanted to check, is it not possible for us or for you as a department to take the service to the most of the time, especially during that period of time, taking the service to the people rather than wait for the people to come to you? Don't you have such intervention of such programs? Then lastly, Chair, for me, it's just a comment. It's for me very disrespectful when you have staff online and we as members are sitting here. I'm not sure if the person is sick or have other commitments, but for me, these are very important. We really want the staff to sit here in front of us, not online. For me, it's disrespectful. I know the member is not here because she's sick. She do have a doctor's certificate. That's why she's online. But for me, it's really unacceptable that staff members are sitting online and we are sitting here. Thank you, Chair.
Thank you, Ms. Member Windvogel. As for the, if I may just comment, as for the attendance online or not, it's a facility that was created, and I think you're entitled to your views. I don't agree with it, Ms. Nkosi. If you and Member Plato addressed a lot of matters, where possible, and you feel you can respond, you're welcome to respond. Thank you.
Thank you, Chair. Yes, indeed. We've noted the comments from Honorable Plato in response to issues of how we address the reporting over weekends. I think it's something we will look at as the department. We can work on it in terms of our systems to ensure that we address that. Backlog in capturing, that is something we've picked up, we've worked on. It's something we should have attended to and addressed before the end of the financial year. The issue, I think, of teenage pregnancy is coming up again. It is really something that is of concern and needs all these multi-stakeholders that Honorable Plato has also spoken to. in the department, we have the platform of the Vaccine Steering Committee meeting that has really brought different groupings of people from the government, from civil society, and other partners. And because the vaccine has now almost integrated into our routine care, we still use the steering committee to monitor how we are doing on vaccination. But we have agreed that we need to expand its role to look beyond just vaccinations, but to look at other issues of population wellness. And I think this issue of teenage pregnancy is something that can really fit into there, because it's something that needs more than just the Department of Health, multi-stakeholders that can come together and provide their contributions towards this common challenge. You know, COVID-19 gave us the opportunity to see that some of the things that we deal with in health are really things that need multi-stakeholders to attend to. Health brings their clinical part, but there are different stakeholders that also need to contribute. Therefore, this is an issue that we are wanting to put onto this now revised and reconfigured steering committee to make sure that we drive this. And also actually the issue of severe acute malnutrition is something that is also cross-cutting, that requires a whole of government and whole of society to deal with, because what we're finding is that from health side, I think also already responding to Honorable Van Gogh's issue, what we have on our side is data that tells you how many children we have seen with severe acute malnutrition, down to aggregate level, where we can tell you that this is prevalent in these areas, in these areas, in these areas. They are seen in these facilities and these facilities and these facilities. So from where we sit, we have data aggregated to that lowest level. But now the interventions to prevent severe acute malnutrition are not within health. They are outside, because nutrition is something that is in homes. Social development then intervenes where people aren't able to provide the nutrition on their own. From us, we see them when they present with the results of not being adequately nutritioned at home. So again, us with the powerful data, we can share it with the relevant stakeholders that can then intervene to make sure, and we can also provide the data again when we can show that there is an improvement. Where there's no improvement, we can also show the data, because we have that capability, we have built that capability that would help us to support the whole of the province response towards this this issue. So I think I've attended then to the comments and questions by Honorable Plato, and dealt with the issue that Honorable Van Goghel, you've raised about details. We have those details, but then they need somebody to take on to say, once you now know that in Khayelitsha, this is where we find this, who then intervenes? Because we would have them down to a patient name, you know. So this is the level of information that we have on our side. You spoke, Honorable Van Goghel, to the issue of the interventions for seasonal staff. We provide services to seasonal staff when they are here, but they are seasonal, so they come to us in those seasons. So when they are not in the seasons, they are not in our care, and they come presenting now with the challenges. Let's say somebody now comes in season, but they are pregnant and they were outside of our system, and they come in positive and then give birth to children that are positive. So this is where now we are finding this, and we are looking at ways to say, how do we proactively mitigate it? But the seasonal nature is then what is impacting on it, because it's people that then come from outside the province and are not in our care and are arriving in our care late, but providing and contributing to the statistics as we see them. Chair, I think I have covered the questions, and if I may, Chair, then just request to register an apology on behalf of Ms. Shen, who had to join online, because the meeting, I understand it was scheduled for a date that was not today and had to be postponed to this date. She had already had a pre-planned visit to the Southern Cape, so she's not in Cape Town at the moment, but had agreed to join online. So we wish to apologize for that, Jay. It's not for any disrespect to the committee. Thank you.
Thank you. So noted. Thank you very much. Members, are there any more questions? And online? don't
No,
see any.
Chair, covered.
Thank you. Member Klaas? Your comment? Yes, President.
Sorry. No, as the health department that we are in, my comment is that we all to have our voice saying to what is happening in health is unacceptable. When we see workers are toiling. So my point, as I am the part of the health, I'm saying that government must pay that people whatever percentage that can suit them, but they must come to that because we cannot people see us as the health leaders and we are not with them. So our voice is that to the health, we need that people to be paid in order that strike to stop. Thank you.
Thank you, Member Klaas. I suggest that you consider asking your colleagues in the National Parliament to convey that message as well. Thank you. Chief Director Nkosi, thank you very much. I hope you're not too exhausted, but thank you very much for a very thorough presentation. Please convey this committee's thanks to all those who have contributed to the compilation of this report. And we look forward to seeing you next time. And we hope that next time you will have even better results. But thank you so much, and please convey our thanks and our gratitude to all concerned.
Thank you very much, Chair, and to the members for the engagement. It's much appreciated, and we will see you next week, I think. Thank you.
Thank you.
You very much.
Yeah, but we'll have it afterwards.
She's going to leave us now.
Okay, but does she have to go alone then?
If we are not adjourning, she can go and eat. Because I also prepare for the department unless the committee adjourns.
Members, before Ms. Nkosi leaves, there are refreshments. We are about to wrap up. I don't know how many resolutions there would be or so. Do you want to break now, or shall we wrap up and then break up? So in that case, I'm going to ask the member of the public and the official to excuse themselves, and we will complete the business that's left. Ms. Nkosi, you're welcome to join us. It won't be too long. There are refreshments. If you feel like a refreshment, you know where it is, and we will see you there shortly. Thank you. Member Fry, you wanted to say something?
I just want to say to the member of the public, to the Imam as well, there's refreshments for him as well.
Thank you. It obviously applies to him as well. Thank you. Thank you, members. Are there recommendations and resolutions in terms of the presentation? Member Plato.
Chairperson, thank you very much. 2 or 3 from my side that with regard to malnutrition, we need to receive some data from the health department with regard to the communities, the areas where we need to understand that. And with regard to death, from where, which areas, so that we can zoom into those areas. Currently, we hear about it, it's hanging in the air, but we got no real information pertaining to that. That 2 issues for me is critical issues. And then the third one, the teenage pregnancy issue, that we need the Department of Social Development and of Health to come back to us, maybe jointly, to come and tell us how best are they dealing with these critical matter of teenage pregnancies, and what are the data saying with regard to that? Are these girls having sex with older men? We need to know that. We need to understand that. I want to leave it with those three. Thank you very much.
Thank you, Member Plato. Member Windvogel.
Chairperson, sorry. I made a note of the three issues. Was is actually for with regard to the, and it's written down here, with regard to the food aid. How is it distributed, and how is it that the food aid distributed by government is missing the poorest of the poor?
Chairperson,
Windvogel.
I mentioned earlier that I want to make it a recommendation in terms of the Brackengate situation. My recommendation will be that then there needs to be engagement between us and the department on the Brackengate issue. So I want to request or recommend that we call the department to come and explain to us the issue of Brackengate, because the minister couldn't give us details. He was just giving there and then. We want more details on the issue of Brackengate, because it's more than 2 years. I think it's more than 2 years that Brackengate Hospital, or what do they call it, hospital, is in existence. So if we can get more information because there's more stories to it that we receive, in order for us to understand and to reply, we need them to tell us. That's my one recommendation. And I also agree with Member Platy, we need more information on the issues that was raised here by the department, that they do have the data and all those. But I also think the department is saying we need all role players of stakeholders in the department. Who's going to initiate it? Because all over you will hear we need the department, the whole stakeholders, but no one is initiating it. So if we can get that answer, I'm not sure how to put it, but who's going to initiate that process? Is it social development or is it going to be health? To start with that process. Thank you, Chair.
Thank you, Member Windvogel. Member Barnes, I see your hand, but first, Member Baku-Vos.
Thank you, Chairperson. No, I just want to emphasize that from my side, I would like to get the information that I requested. The ones you promised that the portfolio committee will receive can be, about the race, the gender of the race, that I ask if they can give us the information on the, what do you call, on the race, and on the district and the gender of the HIV, from 15 to 24.
Are you done, Member Baku-Vos? Thank you, noted. Member Barnes.
Thank you, Chair. I think one of my questions I was promised by the department to get a report on the pharmaceutical stock that are oust and the details of the vacancies, if that can be also put as a resolution down for us to get that information as a committee. And then the second one, I want to latch on to what Member Windvogel raised on the Brackengate. Chair, if you were listening to my question earlier, I've heard the explanation of MEC saying that they're asking money from the Provincial Auditor General, etc. But what is the strategy if we can get a presentation? Because I believe we cannot just accept year in and year out, okay, the contracts are coming to an end, another toy, and this one. How is our approach? I know normally in the House we speak of national government, but we are sitting here as a committee. These are things that we should be looking sharply into. It's people's lives that we are speaking about. It's their jobs that we are speaking about. If the strategy means that we must speak to national government, why not? Hence, I say that that platform must be opened for us to speak and discuss on not only the Brackengate, because we can see that there's pressure on the workers or medical workers, how do we alleviate them from the pressure? If maybe we can get a strategic session speaking around that with the department, it will also assist in moving forward. And for us not only to sit here and throw stones and hear when we are in the house that what about national government? This is an opportunity for us to exchange and see how do we help our entire people, Chair. I just wanted to raise that view. Thank you.
Thank you, Member Buns. Member Bronckhuyse.
Oh, thank you very much, Chair. Chair, in terms of a resolution, if it's possible, later in the year, if the Health Committee, Standing Committee of Health can do an oversight visit to the Somerset West Hospital. My office in the area has been bombarded with complaints. The waiting period there at the hospital, people get to the hospital in the morning and then they are only helped the next morning. Then they have to wait for 24 hours to be helped there at the hospital. So if the committee can commit to do an oversight anyway during the year to the Somerset Hospital, it will be highly appreciated. Thank you. Thank you, Chair.
Member Bronckhuyse, thank you. Do you want an unannounced visit or do you want a planned visit?
I think a planned visit was good.
Thank you. Member Klaas.
Thank you, Chairperson. Chairperson, what we can say that if we have a right as a health committee to meet with agent, because the reason we said we want to meet with agent, we want as the committee to hear from horse's mouth what is happening, because we can say we need this one, this thing is not right, this thing is right, but main thing that we need meeting with an agent. Thank you.
So noted. Thank you, Member Klaas. Are there any more recommendations, observations, comments? Member Fry?
Yeah. Oh.
Just wanted to say that I second Member Plata's recommended resolution on nutrition. I think it's a vital one, and then of course the teenage pregnancy one as well. Thank you.
Thank you, Member Fry. Member Windvogel.
Thank you, Chair. I also want to compliment you on the way you were handling. Sometimes ek raak warm, but your calmness bring me down. So I really want to compliment you on the way you handle the meeting. But I also wanted to support Member Klaas on the urgency of the meeting with the department on the Bracken Gate issue. So really it needs to happen as soon as possible. If you can look at the program, Chair, and because it's an urgent issue. Thanks, Chair.
Thank you. Member Klaas, you had your hand up or not? Are you done?
Yeah, it's fine. It's fine.
Okay.
We need just the agent meeting.
No, I just thought your hand was up again. That's fine.
No, it's not up. Sorry.
Okay. Thank you. Members, if that's all, Member Plato? Oh, are you rising to leave? You're welcome. You are welcome to leave once the meeting is adjourned, which it is now. The meeting is adjourned.